All right, this is a run-through of a radiation safety presentation that I've done, and this is going to be geared towards technologists and students, and it's going to be very brief, so just bear with me for a little while and we'll get some good information out to you that hopefully you're going to enjoy. These are my students. As you can see, they're all very excited about radiation safety. Okay, so our objectives today. We're going to look over some biological aspects of radiation very briefly. We're going to look at some steps for minimizing patient exposure, and then we're going to look at some agency recommendations, especially some information that's come out of late. And then last but not least, we're going to take a look at some experimental data that my students and I have come up with in the classroom. So let's do this thing. Okay, so to start with, radiobiology. As you all know, the law of Bergeny and Tribondeau, I hope I'm not massacring those names too badly. These guys are some French scientists that did experiments with radiation back in the early 1900s, and they figured this out too. But here's a little quote for you, and that most of us understand. Some cells are more likely to be affected by radiation than others. Basically, cells that replicate themselves quickly, highly mitotic cells like you find on the inside lining of your mouth, in your esophagus, all through your GI tract. These cells, your skin cells too, these cells are more susceptible to radiation because they do multiply, and if they get radiated while they're multiplying, then the new cells might not be accurate copies of the old one. Okay, so there's where your radiation damage can take place. So we want to try to limit the exposure to any tissue in the body that is highly mitotic. Now, some cells, intestine cells, skin cells, reproductive organs, these are more easily damaged. These need to be protected. Some terminology here: linear energy transfer, the LET. This is just the rate with which energy is transferred to tissue as radiation travels through the body. Radiations that have high LET tend to be more destructive. Think high-speed neutrons and alpha particles. These things have a high LET. RBE is relative biological effect. So different tissues in the body have different sensitivities. So, for example, the lenses of your eye are more sensitive than your muscle tissue. So RBE figures into these calculations. The LD50, this is something you need to know. LD50-30 means the amount of radiation that will kill 50% of the population within 30 days. LD50-60 is the amount of radiation it takes to kill 50% of the population within 60 days. And this is the one that's most often used, with talking about population exposure, like at Chernobyl or something like that. And then last but not least, we have LD160. This is the dose of radiation that'll kill 100% of the population in 60 days. And this is a lot. This would be like dropping an atom bomb on somebody. And OER is the oxygen enhancement ratio. Low energy radiation can cause the formation of free radicals in the body when the oxygen concentration is high. So tissues that are really well oxygenated, that have a lot of blood flow, those are going to be more susceptible to damage by the indirect effects. And free radicals are just ionized water molecules, basically. Okay, so here's a little question for you. The lethal dose of ionizing radiation for humans is usually given as, is it A, LD50-30, B, LD50-60, C, 50-90, or D, 50-120? And, okay, while LD50-30 is something that we talk about with, that's applied to like laboratory type stuff, but LD50-60 is typically used for humans. So keep that in mind in case you see it on the registry. Okay, so acute radiation syndromes, hemopoietic, and this would be like severe radiation exposure. 1 to 10 sieverts can result in depressed blood production. So, your stem cells, your red blood cells, your blood precursor cells. Those are going to be depressed at this level of radiation. And 1 sievert is 100 rem. That's a lot of exposure. GI, where you're going to have nausea, vomiting, diarrhea, this can occur between 6 and 10 sieverts. So, and it can be like bad. It can be bloody diarrhea. It can actually be sloughing off of the inside lining of the GI tract. And that can kill somebody, actually, just through dehydration, if nothing else. And then CNS. This is a dose of radiation that's high enough to give people seizures, and this takes about 50 plus sieverts, which is 5,000 rem. And that's typically going to be fatal. People that get this dose of radiation, it's possible for them to live provided they get to a hospital. And keep in mind, the occupational dose limit for us is only 0.5 sieverts, which is 5,000 millirem or 5 rem. These sievert measurements are important because now I think as of a couple of years ago, the registry only asks about SI units, so sieverts, grays, air kerma, that kind of stuff, coulombs per kilogram. Embryonic and fetal risks. Nerve tissue in the fetus is at greatest risk during weeks 8 to 15 post-gestation, so early on in the development of the fetus. But the thing is, with fetal exposure, most of these effects are only estimated because it's hard to distinguish. If a baby is born with a birth defect, did that come from radiation or did that come from some other reason? Maybe the mom got exposed to some chemicals, or, it could just be something that we don't know what caused it. Now, most procedures that we do, chest, abdomen, stuff like that, remember, the fetus is inside the mom's abdomen, so the mom's tissue is going to provide some protection. So typically, the amount of radiation that reaches the fetus is going to be less than 0.1 sievert most of the time. So the amount of radiation exposure is low. But we don't know for sure, so shield your patient and use a LARA. We only x-ray pregnant people under the most only select circumstances, and it requires that either a doctor or a PA come in and counsel the mother and get her to sign a waiver, basically, prior to us doing the exposure. So that's not something we do all that often. Now, how can we minimize our patient exposure? Well, for one thing, we can use high kV, low mass techniques. Now, my students are really good. I noticed here lately when we're down in the lab and we're setting up for an experiment, they automatically dial a high kV. That's just the way that's where their mind is. That's how they think. And so they just naturally push the KVP higher. Collimation. Close collimation makes good images. It also reduces the skin exposure to the patient, so that's always a good thing. Filtration. All of our equipment has to have aluminum or copper filtration. All equipment must have 2.5 millimeters aluminum equivalency, and most of our tubes have between 3 and 4 millimeters aluminum equivalency total filtration. And this goes back to the NCRP reports where they make these suggestions, and it's good suggestions. Now, distance. Keep the SOD, that's the source to object distance, the distance between the tube and the patient, as large as possible. Now, we are legally bound to use 12 inches minimum for portable radiation. That's for portable X-ray and for portable fluoroscopy, C-arms. And for stationary equipment, we need a minimum distance of 15 inches. You never want to get closer than that to your patient. And that would be ridiculously close. We would never do that. And stand back during fluoroscopy. That's for our benefit more than the patient's. And of course, shielding. We want to shield those patients. Now, something I wanted to talk about. A couple of years, or I guess a year ago, January 13, 2021, in Practice Management, which is a publication that comes out from time to time, they said that the NCRP was indicating that, since there's not that much risk of damage, that we should just ditch shielding. So therefore, since shielding might cause us to do a repeat image, we should just get rid of it. And all these other groups jumped on board. The American Board of Radiology, the American College of Radiology, all these groups. So, it looked like shielding was going to go by the wayside. However, if you go back and look at the NCRP report, what they actually said in their January 12th statement was that we might not should use gonadal shielding for abdominal and pelvic radiography, especially for women. Their gonads are in the pelvic bowl, and so if we try to shield them, we might obscure the anatomy. Okay, so they said they do recommend against shielding only in these specific circumstances. There's no reason to not shield a patient if you're doing chest x-rays or if you're doing extremity x-rays. Anything that's away from the pelvis, we can still shield like we normally were. So I think there was a big misunderstanding as to what the NCRP was really talking about. But what do our agencies say? Well, the ASRT says we should be shielding. We should be shielding ourselves and we should be shielding our patients. Radiologic technologists are ultimately responsible for these radiation safety techniques because a lot of doctors even don't have this kind of training and they might not 100% remember, or maybe they went through a class in some basic radiation safety but then they quickly forgot it if they don't use it every day. So we're the ones that are actually responsible for making sure everybody's reminded to put on lead. Now the JRC, what do they say? The JRC ERT is our accrediting body, and they have a lot to say about student and patient safety, including we're supposed to be teaching our patients to keep everything as low as reasonably achievable when it comes to radiation. And prior to clinical assignment, we're supposed to be telling our students about radiation safety for themselves and their patients. So the JRC thinks it's pretty important. The state of North Carolina tends to agree, it seems. North Carolina statute says gonadal shielding of not less than 0.5 millimeter lead equivalent shall be used for potentially procreative patients during radiographic procedures in which the gonads are in the direct useful beam, except for cases in which this would interfere with the diagnostic procedures. So they want us to shield too. And what do my radiography students say? Well, this was some experimentation we did, and I won't hammer you with these numbers, but basically we tried at different KVPs taking images with and without shielding. Now these shields were not in the primary beam, they were just roughly in the area of the patient's gonads during these radiographic examinations of the abdomen, and this is what we found. If you just put some shielding approximately the level of the patient's gonads or a little below so that it's outside the collimated field, and then we put an image receptor where the gonads would be, and we saw some differences. We saw anywhere from 73 to down to 49 was the lowest, but still 49, that's not nothing. So even at high KVP, putting a shield on the patient absolutely does help cut down on some of the radiation exposure. So all this, what does all this mean? Well, bottom line, we know what high doses of radiation do, and it's not pretty. We're not 100% sure about low dose radiation because the effects take a long time to manifest. Therefore, a LARA is the best approach. We should shield all patients because this constitutes a best practice approach to radiation safety and adheres to the ARRT professional standards. And we want to be perceived as professionals. All right, so thank you all very much for attending my very brief presentation. And I hope you learned at least a little something. So if you need to, just go back and take a look again, anything you missed the first go round. And regardless of what any report says, shield your patient. That's the best way to go. It makes your patient feel better. It makes you feel better. So stick with the shielding. Do read these publications, but take them with a grain of salt. All right, thanks again, and have a great day.